So basically, I'm giving a talk about one of the most common procedures that we do in neurosurgery, which is about anterior cervical approaches and the anatomy related to this. The rationale for anterior decompression is obviously it's direct vision. You've got herniated disc, osteophytes, OPLL, and sometimes interbody fusion when required. The goals are for decompression, stabilization, and indications include the degenerative conditions, trauma, tumor, and infection. The types of ventral approaches are various, but two most common approaches that we can take is either ventral and the other one is anterolateral. So basically, one is coming behind the carotid artery, whereas the other one comes in front of the carotid artery. This is the most common approach that we use for our routine cases. So this is the approach we take. So if this is the front, so thyroid is here, trachea is here. So we push the thyroid and trachea immediately, and we go push the carotid laterally. And this would be our track that you'd be taking. Esophagus is also pushed immediately. So these are the different types of surgeries that we can do when we're doing anterior cervical surgeries. The advantage of obviously that you're addressing the pathology where it is, and so it's easy to decompress. And it's good for all kinds of postures. It's very simple. You don't have to cut the muscles. Risk of infection is really low. The structural graft fusion is very easy to perform. And you are following the tissue plane. So there is no muscle cut. It's well tolerated, less painful and posterior. And majority of the centers are now doing this as a daycare procedure. History goes back to Smith, Robinson, Cloward, Bailey, and Bagley, and this all has been going on for last 80 years or so. Relevant clinical anatomy. So muscles, there are two groups of muscles. One is superficial, and obviously sternocleidomastoid, and our deep muscles. And there are triangles, which we all know of, the three triangles that we generally study. And then you've got deep muscles, and these are the important longus colli muscles that you need to push laterally and dissect in order to put your retractor underneath, which in majority of the patients we perform. So I think it's important to understand its relationship to the vertebral body. The body of the hyoid bone is important element. At the same time, you've got the laryngeal prominence, you've got the cricoid cartilage, there's a lamina of the thyroid. So all of these have got relevant reasons that they are there, and they make our life easy if we don't have an image intensifier to start with. But ideally, you should also double check all these measures with the image intensifier. So you need to be careful what's underneath and where it's coming from. So if you look at this, so for example, we take the skin off. So if you have got you have platysma on both sides, and you've got the superficial muscles. And once you go in and take the superficial muscles out, then you've got the longus on both sides, and eventually you're left with the raw bone itself. The relevant anatomy, obviously, we're going to be talking about the vessels, nerves, and viscera. And the nerves, which are two important nerves that go from here, is the vagus. And vagus gives rise to the recurrent laryngeal on the right, which goes underneath the subclavian, whereas on the left, you can see it goes straight up, and this curve obviously comes straight up from here. So there is a difference in recurrent laryngeal nerve on both sides, and visceras are important in this area. Of this, esophagus is the most important one. The vascular anatomy is the anterior jugular system. You come across it, and the important thing is you make sure you dissect in between. And if it's a single level, it's straightforward. If it's more than one level, sometimes you may have to tie a vein or coagulate it, or may have to tie one of the arteries which come in your way if you're doing a multi-level procedure. Thoracic duct usually comes down at the lower end and curves in and enters here, and you need to be wary of it on the left side. The vertebral artery, it's important to understand, if you know the anatomy, that it enters from C5 in 7%, and C6 90%, and C7 in 3% from the foramen transitorium. So, and there is an aberrant course in 2.7% of these patients. So it's important to understand it doesn't enter the C6 foramen transitorium every time. So 1 in 10 patients will have a different entry. So you need to be wary of that. The glossopharyngeal, hypoglossal, vagus are important. We talked about recurrent laryngeal, so one on this side and one on this side, and you need to be careful. And they lie underneath the longus colli, and you need to remember that. The superior laryngeal nerve C3-4 level. The superior thyroid artery is at the same level as well. The recurrent laryngeal nerve is on the tracheo-esophageal groove, as we talked about. On the right side, it may come across at C5-6 and may not recur. So that's important to understand as well. So when you're operating, you need to be careful where exactly this is on the right side. Majority of the right-handed surgeons operate from the right side. So if we see this, so this is the recurrent laryngeal nerve on the left side, whereas this is the recurrent laryngeal on the right side. And you can see that this is the vagus nerve going up on both sides as well. The relevant anatomy for sympathetics, the sympathetics run underneath the longus colli. So when you're cutting, you don't want your diathermy to be too high. And the three ganglion, superior is the level of C2-3, middle at C6, and still at lower down and C6-7. So if you look at this, again, you've got the three ganglions, inferior, middle, and superior ganglion, and they're all seen here, along with a recurrent on this side, which you can see, which is going up, and the recurrent on the left side is slightly lower, which is down here. Surgical techniques, both sides are okay, whichever way you're comfortable. Generally, right-handed people operate from right side and left from the left. On the other hand, if you're using a microscope, you need to be careful that you want to be decompressing both sides, because when you use microscope, you generally do your side better. When you're using headlights, then you generally do the opposite side better with loops. So you need to be careful that you are decompressing both sides if required. You identify with C-arm, skin incision is routine. So transverse incision, the levels we're going to be talking about. Many times I use skip incisions when you've got two, for example, 3-4 I'm doing, and 6-7 I'm doing, I do with two separate incision, and they give very good cosmetic results. Skin incision, landmark we already talked about. So C2-3 is the angle of mandible. Hyoid bone is at the level of C3, generally C3-4. This level is what you use. Thyroid cartilage, so you see is a level of 4-5 required at C6, and the supraclavicular groove is 6-7. If you've got a very long neck, then you need to be careful, and you need to look at the X-ray to confirm that. Blunt and sharp dissection, so you can use both, and you put your finger in once you've separated the fascia that I'm going to show shortly. So you've got the deep cervical fascia, the pretracheal fascia, and the prevertebral fascia. And all these are important to separate when you're going in, because if you don't cut this, then you won't be able to put your retractors in the right place. The placement of retractors are important. And why is that? There are different kinds of retractors. We usually use trimline kind of retractors, in which are the sharp retractors go underneath the muscles on both sides, and blunt go on each side up and down. And you can use distractors. I generally don't use it because it gives rise to interscapular pain, but whatever your preference is fine. Obviously, you resect the disc and you take out the unconvertible spurs by using drill. So the important thing when you're using drill, you need to use either matchstick, a matchstick, or a diamond when you're taking this out, and not go underneath and cause serious problems. We don't use curettes like that anymore when we are taking care of the back part of the osteophytes. Decompression has to be adequate. Again, matchstick and diamond drill is important. You need to decompress both sides equally. You can't be decompressing just one side or making a very narrow trench. It has to be adequate decompression. The grafting and plating, again, the screws should be in a majority of the place now are dynamic. So your screws should be direction always has to be either away from the center, and you're coming in medially. Away because you want to make sure that when the dynamic plate sags down, it doesn't cause any problem. And it's medially because you want to be avoiding the nerve as well as the vertebral artery in case your plate is slightly crooked. So I think that those are important tricks to remember. You should not have a plate this big. The plate should be as small as possible, and your screw should be directed away. So you're going up, not straight. And obviously, when you have got a deformity, you can use a much bigger cage to elevate the whole thing. Another trick regarding deformities, you put screws up and above and below, and then you bring the plate close to the bone itself by the screws, and the whole deformity corrects by that trick as well. The claims are that biomechanically it's stable, facilitates fusion, promotes resorption of osteopods, widens neural foramen, The facts, proven facts are the graft and graft site complications could be high in inexperienced hands or people who don't have enough of exposure, whereas adjacent level disease could be up to 20%. If you go on an exposing level above and below at the same time, you need to be directed just at the level that you'd be working at. Graft is not necessary for a biomechanical stability, and there are multiple studies that have shown that. So short-term results, immediately, brilliant results. Long-term, there's no instability, fusion up to 28 to 100%, with very good stabilization with all kinds of different material that you use. So with simple discectomy, the results are same as your a graft that you use. I generally use graft in every case, but I'm much more comfortable because I can correct the deformity at the same time. And once I decompress, I know that osteophytes won't be coming back there. If it's a single level, you can get away with without any kind of graft. If the disc is soft, you can do a simple discectomy or maybe anterior foraminotomy or posterior foraminotomy. Large osteophytes, you need to be thinking about fusion, which majority of the cases in our part of the world we see. If the disc height is less than 4 millimeters, you can think about simple discectomy. If it's more, then you may be thinking about ACDF because you don't want the whole thing kinking on top of you. Deformity, if it's kyphotic, then you think about ACDF. If it's lordotic, simple discectomy, you can get away with it. So degenerative cases, ACDF time-honored, gold standard, simple discectomy, as good as ACDF in some people's hands. TDR in some studies have shown promising alternative, yet long-term studies have yet to prove that. Anterior foraminotomy can be performed something like this. So you can approach anteriorly, and what you do is you take the anterior lateral 1/3 of the vertebral unit, which is direct nerve decompression. The uncovertebral spurs can be taken out anteriorly. It is special care that you don't want to be disrupting the disc itself. So, you know, this part of the disc laterally and the bone can only be taken. I've done about 10 of these and all of them are doing well over a long time, but I'm not sure that indication is huge here. It's very short indications. So you go in something like this with a microscope or endoscope and can decompress anteriorly. The anterior cervical foraminotomy, there are 3 different types. And what you need to do is open up the joint like that. And this is the area that you're going to be opening up and decompressing and taking out the disc from front. So generally speaking, it's the transcervical approach is a classical approach that's generally used. And you need to put some kind of a retractor on the vertebral to make sure that there's enough space and your decompression is adequate and you're not harming the vertebral there. So you drill all the way to the canal, lift it up and decompress the root like that. And so this simple procedure like this can result in a decompression as easy as this. Anterior oblique corpectomy can be used where you don't want to be using a graft or a plate. And some of my friends routinely use it. My experience is only a couple of cases. And the results are very good if you're good at it. But again, you have to come lateral to the carotid. And so it's an anterior lateral approach. So you open something like that. So you're coming at an angle. So this is the patient that we're seeing on an anterior lateral approach and the decompression and the dura seen there. So you've got something like this. And once you open up, your results are pretty good in these patients. So you open up and you do a post-op. So if you have an osteophyte here, you have to come all the way laterally over there. So the results are very, very good. We need to be wary about the approach-related complications, injury to the adjacent tissue, organs. If any time you get an infection in cervical disc, then you think about it, the problem is probably related to esophagus. So the risk has gone down to 1 in 600 now for anterior cervical approaches. And if you do get an infection, be wary that did you hurt the esophagus by any chance? That's why you're getting some kind of infection. Instrument graft-related problems can happen if you don't put the screws. You don't think biomechanically about this. You're not worried about the C2 as well as C7, T1 angles. Hematoma you can get very rarely, but if generally I put in a drain for 24 hours and that works very well. Donor place problems, if you do take that, then obviously it can happen, and non-union can happen, which can give rise to neck pain afterwards. Approach-related dysphagia, recurrent laryngeal nerve, esophageal injury, very rare nowadays. vertebral artery injury, I haven't seen, hopefully I'll never see it. Tracheal injury, hematoma, and infections are there. Durotomy you can cause, but generally doesn't cause much problems. So complication avoidance, you don't want to be jumping on it. You think of this as your own eye, and what you would drill on your eye, you can only drill like that. So you can even leave this bit of bone if it's floating, and you can have pretty decent results with that. When you're putting in a graft, don't tap on top of the graft. It should be on the side. And usually nowadays, majority of our hammers and the blade that we use to tap in the graft are have some kind of a protective element. So please use that and be careful. You don't want to be hitting the cord. So all this is very important for us. And when you're drilling on the side, you need to be wary that where exactly is the joint. How do you find that you've done an adequate decompression? You put some kind of a hook underneath and feel the pedicle. Where you can feel the pedicle, you've done enough decompression. So that is important. Sometimes enough venous ooze can show you that as well, but that is the absolute confirmation. So I'm grateful. Thank you. It was wonderful to give a talk here. Thank you, Vlad. Thank you all, guys. Pleasure to be in this forum.
Salman, thank you. It was great, very educative and excellent. I would like to start with the spine again, hearing you. Are there any questions from the faculty?
Yes.
Imad?
Imad, yeah, I just want to complete the sessions with the Salman. If he can give a few comments on artificial disc, his indication and patient selection.
Yeah, I think the most important thing is that when artificial disc came in, the initial big vogue, as we know, is to use all those that new things come in. And with time, we realize that everything that we see is not honey. So the indications are now restricted. We know this. So it has to be a soft disc, a young patient, radicular pain. Some of my friends who have shown really bad results from various large trials are because the indications were very, very bad in those patients. So we had myelopathy, we had OPLL, we had osteophytes, we had old patients, we had patients with multiple comorbidities. So I think because of that, artificial disc got a really bad name. And then there was heterotopic ossification, because people were going at multiple levels, leaving a bit of bone underneath as well and not washing enough. So nowadays, we only use artificial disc in those cases where patients are young. They don't have much neck pain. They don't have much deformity. They don't have any osteophytes, and they don't have myelopathy. Some of my friends are still operating with myelopathy and giving good results, but good for them. But I can do better results with what I've been doing all along, a fusion.
And what about cages with the screws, internal screws? Do you replace them as you feel they are better than plating?
Okay, so there are two types of screws that are available along with the cage. One is you've got double screws, whereas one is a single screw. The single screw is really not a good one, because in rotation, you can cause serious problems to it. One of my friends from Europe routinely uses, he says in his hands, is pretty good, but he leaves the collar on for 6 weeks, which we don't in any of our fusion. I leave a collar on for 10 days and then off. With the double screws, yes, it's pretty reasonable. The only problem is that if your screw angle is too steep, then you would cause breakage of the end plate and on both sides. And I've seen many surgeons do that. So I get to see a patient like that with that kind of plate one every 2 months. And there's people don't know that angulation has to be correct. And if you're going too steep, you will break the end plate and cause that end plate to be broken, and it comes into your canal and can cause serious problems.
Thanks, Salman. Very good comment.
Most welcome.